Today we're joined by Dr. Jorge Marrero, who is the co-chair of the writing group for the HCC Guidance. He's from UT Southwestern, and we're really happy to have you today.
My pleasure.
So first of all, tell me a little bit about what's the difference between a guidance statement and a guideline statement.
So according to the AASLD, when we started this endeavor, there were two documents that we needed to produce. One was a guideline. The guideline was based on data that was coming from randomized trials, and more than one, in which we could do a meta-analysis in order to determine the overall efficacy of the treatment, of the diagnostic tests, etc. So it was based on 7 questions, clinical questions, such as what is the best surveillance test for liver cancer, and then the data group would inquire, do a data search, and came up with a conclusion. So it was basically narrowed to clinical questions in which there was robust randomized trials and a lot of data.
So we know that hepatocellular carcinoma is a big problem. Tell us really what's the scope of the problem today?
The estimated number of hepatocellular carcinoma cases in 2018 is about 40,000. The main issue is that over the last 20 years is the cancer that is the cancer that has increased the most in terms of cancer-related deaths. So, and also has become from a very uncommon cancer to now, in terms of incidence, a top 10 cancer. So it's a highly lethal tumor.
So these guidance statements came out in 2017. What have you learned over the last year about these guidance statements, and are there areas for concern or areas for potential revision down the line?
Yeah, there's always room for improvement. So in terms of the guideline standpoint, that we asked the 7 questions based on data. Since we produced the document and it was published, there have been new randomized trial data on novel therapies for liver cancer that was not covered in the guideline statement. However, in the guidance statement, we actually covered the newer randomized trials and data for systemic therapy. So there has been a significant difference and a change in the field in terms of the new levels of evidence.
Well, let me ask you, you were also writing on that waiting on the outcome of some studies and some trials, particularly a lot of these phase 3 trials that were evaluating the survival benefits of sorafenib versus radioembolization in hepatocellular carcinoma. What have you learned, and what do you think you may want to add to these statements based on those trials?
So we were not able to include all the newer trials in the guideline statement, but we did include them in the guidance. Pertaining to the trial that you allude in terms of sorafenib versus radioembolization, there were 2 randomized trials in Europe mostly, and the data showed that sorafenib was superior to radioembolization. So in terms of patients with advanced hepatocellular carcinoma, sorafenib is still the first-line choice instead of radioembolization.
So you have a lot of experience with writing guidelines now, and there's a lot of debate on how often should we update guidelines or guidance statements. Given your experience now, what do you think? Because there's been decades between guidelines in some cases.
In the field of hepatocellular carcinoma, because it's moving so rapidly with novel changes, novel discoveries, novel agents, different pathways for cancer, and these pathways may lead to newer therapies, my vote would be to do a living document, meaning that it can be updated annually or maybe perhaps more frequently as novel therapies are evaluated in phase 3 trials or as they get approval by the FDA. So I think probably a more living, quote-unquote living document that can be updated rapidly. And the AASLD, there's an example in the AASLD with the hepatitis C guidelines. They were adopted quite regularly as newer therapies were developed.
I think you make a really great point. We're in the digital age, and using these digital technologies to guide our therapies makes a lot of sense. One final question. you know, with all of the drugs that are out there to cure, you know, liver disease, hepatitis in particular, how do you think that's going to impact hepatocellular carcinoma going down the line?
I think pertaining to hepatitis C, the people that get cured have a much lower rate of developing liver cancer than the people that the hepatitis C is not cured. So it definitely has made an impact. However, this is a warning. Curing hepatitis C does not eliminate the risk of liver cancer. It's a significant reduction, but does not eliminate. So if people have significant scar in the liver and their hepatitis C is cured, they still need to undergo surveillance for liver cancer because curing it can lead to improved outcomes.
Well, thanks so much for joining us today. This was great to chat with you about these guidelines and guidance statements, and looking forward to a great meeting.
Thank you very much. Happy to be here.
AASLD TV has all the coverage you want from this year's conference. Be sure to check out all of our content, which is updated every single day here on YouTube during the liver meeting in San Francisco.